Hi, and welcome everybody. My name is Viren, and I'm one of the social media editors for Journal Chest. Today, I'm bringing to you the Journal Club webinar discussing the study, the impact of esophageal pressure measurement on pulmonary hypertension diagnosis in patients with obesity. I'm joined by the study authors, Dr. Ghaleb Khirfan and Dr. Adriano Tonelli. Welcome, both of you, and thank you for joining us.
Thank you.
Thank you, Viren. Thank you for the invitation.
Of course. So I have no conflicts to declare, but I would love for Dr. Khirfan to introduce himself.
Thank you so much for having us here today. I am Ghaleb Khirfan, and I'm currently a pulmonary and critical care physician and pulmonary hypertension specialist at Spectrum Health, joining you today from Grand Rapids, Michigan. I'm very happy to be here along with Dr. Tonelli, who is my mentor. And we're very excited to discuss our study, which I conducted while I was a pulmonary and critical care fellow in Cleveland Clinic. Thank you for having us today.
Awesome.
My name is Adrian Antonelli. I'm a staff here at the Cleveland Clinic in the Respiratory Institute. I have no conflicts of interest to disclose, and I appreciate the invitation and look forward for a good discussion about this study.
Amazing. And here's the DOI for those of you looking at the screen. This journal article will be released in September 2022, so this month's edition. All right, so I wanted to start off with the literature that is known on this topic. So we're talking about esophageal pressure measurements and at the same time, doing right heart catheterizations to understand hemodynamic changes. So what is the known literature and what's the gap we're trying to address?
I can take that question. So the literature on the use of esophageal pressure to estimate the intrathoracic pressure is mostly in the medical ICU, particularly for adjusting PEEP in subjects with obesity. There's really no literature, as far as we know, in the use of these to adjust the intravascular pulmonary pressures during right heart catheterization. The idea of the study came through one of the co-authors, Dr. Khatipoglu, who was in the ICU and put a esophageal balloon in a patient, an obese patient, to adjust the PEEP. And the patient also had a SWAN, and he noted that the changes in the esophageal pressure also appeared to affect the pulmonary pressures, inflating, elevating the values of the pulmonary pressures. As the intrathoracic pressure increased, the pulmonary pressure was also elevated, and it's in that particular patient, and came with the idea, oh, it's something that we could also look in the right heart catheterization lab in patients with obesity. And so we did a preliminary study that was published in the Annals of Thoracic Medicine, the White Journal. Was a preliminary study on 19 patients with obesity, that we showed that measurements of esophageal pressure has a great impact in the hemodynamic classification. But at that time, we used a more complex, sophisticated tool to record the esophageal pressure and the pulmonary pressures with a completely separated device and a more sophisticated system that was not really applicable. So for this study, we moved these to just a regular monitor that we use to do the right heart catheterization. So it can certainly be done in any catheterization lab, the measurements of esophageal pressure, if you know how to place a esophageal balloon and be sure that's appropriately placed. So the main goal of this study was to see whether the intrathoracic pressure has an impact in pulmonary hypertension diagnosis and hemodynamic classification in obese individuals.
Perfect. And of course, the whole question is, does this change how we address these patients. So we'll get to that with our studies. Thank you for explaining that. I think the natural next question here is to understand how the study was designed, and then who are the patients that you included, who are the ones that you excluded, and why?
Awesome. So I can take this question. This was actually a prospective study. We screened patients who were referred for right heart cath in the outpatient settings, mostly for evaluation of suspected pulmonary hypertension or a re-evaluation of a known pulmonary hypertension diagnosis. We included patients with obesity, defined as BMI more than 30, and those who were found to have elevated mean pulmonary artery pressure during the right heart cath of more than 20 and elevation in the pulmonary artery wedge pressure of more than 12. The reason we selected this subset of patients is because we wanted to identify a group of patients that would benefit the most from esophageal pressure measurements. And that's why we selected this group of patients. We actually excluded patients who could have other causes for elevation in their intrathoracic pressure. For example, patient with obstructive and patient with restrictive lung disease, and for sure, patients who had contraindication for placement of esophageal balloon catheters. For example, patient with varices, recent surgeries, epistaxis, or latex allergy, or the patient whom we suspected that they will have poor tolerance for the procedure. So in a nutshell, after the right heart cath was performed, if the patient was obese and we noted that they have high pressures, we asked them if they would be willing to undergo placement of the esophageal catheter. And then we measured the pressure after inserting the catheter, and we adjusted all the hemodynamic measurements for the simultaneous measurement of the esophageal pressure. So we were subtracting from the end expiratory measurement mean pulmonary artery pressure, we were subtracting the end expiratory esophageal pressure measurement, and same applies to the wedge and the rest of the measurements. We measured those in the sitting and as well in the supine position, and as well as an average reading across the respiratory cycle in order to account for the respiratory variation in hemodynamic measurements.
Perfect. So to just put it very simply, maybe a little too simply, we just removed the esophageal pressure sort of as a marker of extrinsic, elevated, or non-cardiorespiratory hemodynamic pressure. So we removed that from what we're getting in the vascular system, and to see what that does to our vascular recordings, right? Fair enough?
Yes, 100%. And I mean, if we can show table 1 to see the subset of patients we included in this. As you can notice here, we included a total of 53 patients, and all of them were obese. The average BMI is 44, which is high. And we presented here the hemodynamic classification based on the conventional end expiratory pulmonary artery pressure measurements that the guidelines recommend. And this hemodynamic classification is based on the 6th World Symposium of Pulmonary Hypertension Classification. Patients, the majority, as you can see, of our group of patients has evidence of post-capillary pulmonary hypertension, defined as pulmonary artery pressure more than 20 and wedge more than 15. The second largest groups were patients with combined pre- and post-capillary pulmonary hypertension. And a very small number of patients had evidence of pre-capillary pulmonary hypertension.
Perfect. Would you like to talk about the sort of cardiac features in baseline characteristics while we're on table 1?
Yep. So here we're presenting the baseline function, like baseline pulmonary function test. We have the FEV1, diffusion lung capacity, NT-proNP results. As you can see, we're also the mean left ventricular ejection fraction was normal in those subset of patients. We can also see here the distribution of RV dysfunction in those subset. The majority of them had the normal RV function. About 21% of them had evidence of mild RV dysfunction on echo, and around 20% has evidence of moderate to severe RV dysfunction on the echocardiogram.
So I think this was super important to me because as an ICU physician, right, we often run into the situations where you're, seeing those higher than you expect sort of numbers on SWAN, and then you have RV dysfunction, and the question starts, right, is that cycle? Yeah. Is it the chicken or the egg? But this will help understand some of that, right? Okay, great. So my next question is to understand the impact that these esophageal determinations had on measurements of numbers for pulmonary hypertension in terms of diagnosis and classification.
Okay, so I can take this question if we can see the figure 2, the hemodynamic classification. Okay, so again, as I mentioned in the and at the beginning, we used more than one method for classifying the patient in terms of pH hemodynamic classification. On the far left side, you can see the end expiratory pressure measurements, which is the conventional way of how we are actually reporting data from the right heart cath. In the middle, we can see something called the average pressure measurements. And this is where we take an average across 3 respiratory cycles in order to account for the variation and the respiratory oscillation across the respiratory cycle. And finally, on the far right side of the screen, we can see the adjusted end expiratory pressure measurements. So when we started with the conventional measurements and conventional way to record that, we noticed that all of our patients have a diagnosis of pulmonary hypertension. And the majority of which, around 40 patients, have elevation in their wedge of more than 15. So they have evidence of either post-capillary pulmonary hypertension or combined pre- and post-capillary pulmonary hypertension. Only one patient had evidence of pre-capillary pulmonary hypertension, and 2 patients have evidence of undifferentiated pulmonary hypertension. Undifferentiated pH is not clearly mentioned in the guidelines, but these are a subset of patients who have a mean pulmonary arterial pressure more than 20. Their wedge is less than 15, but their PVR is not more than 3. So they could have a PVR of 1 or PVR of 1.5 or 2. So those are patients not clearly defined how to classify them. So this is what we are referring to undifferentiated pH here. So as you can notice, once we place the esophageal pressure and we use the adjusted pressure measurements and we eliminated the effect of intrathoracic pressure, we can notice that in up to 12% of in up to 12 patients, which is around 25%, we eliminated the diagnosis of the pulmonary hypertension. And you can imagine all the stress, the anxiety, and the extra testing that can come along with that. And also, you can notice the significant reduction in the group of patients who were labeled previously as having post-capillary pulmonary hypertension or combined pre- and post-capillary pulmonary hypertension. Those were reduced from around 94% to 19%, at the expense of being able to identify few more patients who would be reclassified as pre-capillary pH. And we all understand the importance of that because those are the group of patients who would be benefiting from the use of pulmonary vasodilator in this condition.
There's an important concept here, is that when you adjust by the intrathoracic pressure, you adjust the mean pressure and the wedge to the same level. So the transpulmonary gradient doesn't change. Therefore, the PVR does not change. Right. You can only reduce the post-capillary component here. So that's why the most that you see here is a reduction in the post-capillary component, and the pre-capillary component you do not affect. So the fact that you had a higher number of pre-capillary at the end is because you remove the combined, you decrease the combined pre and post. The transpulmonary gradient doesn't change, and the PVR does not change by adjusting for esophageal pressure.
Yep, and that's been borne in previous studies in healthy individuals as well, that the variation, right, in pressure is not borne in vascular resistance. So you can think about it like a vice grip around the chest. This is essentially causing a post-capsular increase. And I just have the figure 1 pulled up, which highlights the point you're making if you want to extrapolate on that as well.
Yeah, you see in panel B that there is an association with the R of 0.4 between the wedge at the end of expiration and the esophageal pressure at the end of expiration. That's significant. The squares in gray that you see in panel B are the patients that continue to have a high wedge after correction. And this is the most significant finding of our study. The esophageal pressure, as you see on the panel A, does not significantly correlate with mean pulmonary arterial pressure. Mean pulmonary arterial pressure can be increased by a variety of factors, not just the wedge. And so by adjusting for that esophageal pressure, you are able to remove some of the patients from having PH, as you see the blue squares, but the association between the two, esophageal pressure and mean pulmonary arterial pressure, is not as significant as we saw in panel B. And also the PVR, as we discussed before, there is no relationship between PVR and esophageal pressure, since the transpulmonary gradient moves in the same direction for the mean pressure and the wedge at the same time, so it doesn't really change that component.
Yep. And I was going to ask you this later, but any hypotheses on, you did mention there's a number of factors that impact mean pulmonary artery pressure, but any particular factor that we know impacts this more than the others?
No, I mean, obviously the precapillary component can certainly affect the mean pressure. High cardiac output can affect the mean pressure, and the wedge can affect the mean pressure. So you have too many factors, and the esophageal pressure, at least in these 53 patients, didn't really significantly track with the esophageal pressure.
Got it. All right. So let's then move on and discuss the findings that you describe in sort of figure 3. So what were the variations in these hemodynamic variables with patient positioning, supine versus sitting?
One of the things we tried to do here was that, hey, is there a way that we could predict the esophageal pressure so we don't have to put the esophageal balloon in these patients? And would sitting be a good surrogate marker of the adjusted pressures by esophageal pressure, or would the respiratory oscillation be a good information or a good marker of an elevated esophageal pressure? And although sitting significantly reduced the number of post-capillary PH patients, it did not fully equate to the esophageal pressure adjusted measurements. As you can see here in this figure on the left side panel, the supine position, in blue, you have the wedge pressure with the A and the V waveforms. On top, you have obviously the EKG in yellow. And then you have the esophageal pressure in red and the adjusted pressure. So that would be the wedge minus esophageal pressure in gray at the end, which would be the adjusted value. In this case, let's say it was around 3. So when you adjusted the wedge, it went down from 25 at the end of expiration to a value of 3-4 millimeters of mercury. So then when you sat the patient, the esophageal pressure drops, and we will then see probably in table 2 that the end of expiration esophageal pressure dropped from 14 on average to 5. So that's a drop of 9 millimeters of mercury. If you go back to figure 3, you see that in figure 3, the esophageal pressure drops, but that much. In this case, it dropped from around 20 to around 10, and but the wedge also dropped. And when you adjust, you get an adjusted value. But as you can see, the wedge in a sitting position adjusted is a little bit lower than in supine, because in the study we also found that changes in position in these obese individuals, the pressure drop, 70% of that is explained by a drop in the esophageal pressure, while 30% is due to other factors. So in this case, it dropped more than what would you expect by the drop in esophageal pressure. And likely that's pooling of blood in the lower extremity and decreasing the preload. So just sitting, it kind of gets you to the more appropriate values, but it's not the full correction. So we support the use of esophageal balloons and seating in the absence of having that availability readily available in your cath lab.
Right. So to summarize results, significant amount of one diagnosis of PH. That's huge, right? Your just diagnosis has changed, classification of PH has changed, and then more importantly, it's the what we may consider as a useful sort of surrogate maneuver to calculate or to do these measurements, which might be sitting, is maybe not as good as one would think, right? I think that's a very. Does that encompass broadly the findings?
Yes, just think about this. I mean, when the results, we analyze the results, this is one of the I think one of the main points of the study is that, for example, in this patient in supine position on the left panel there, you see a pleural pressure of around 20. Imagine those patients in your ICU that you measure the wedge is 25.
Right.
And then you start diuresing them and the patient doesn't get any better. The creatinine goes up, the bicarb goes up, and you're like, how can this be possible? I mean, the wedge of 25, this patient should be getting better with diuresis. And then you put the esophageal balloon, you notice that the esophageal pressure is 20, you adjust, it's only wedge is 5. That patient really doesn't need to have more diuresis.
Yep.
Yeah.
Is that long-term fable, right? That sometimes incomplete or inadequate information can be more dangerous than no information, right?
Yeah.
So yeah, no, agreed. So, I'm going to ask you shortly to sort of close all this by telling us how clinicians at bedside can implement this, right? But before we go there, could you tell me some sort of shortcomings or some, things that you may do differently with the next study?
Yeah, I mean, I can take this question. One of the shortcomings of this study is actually it was a single center settings, and we did not include patients from other centers. The other shortcoming of the study is that we were very particular about the selection of patients in whom we want to insert those esophageal balloon catheters. So we selected the patients with obesity, with elevated pulmonary artery pressure. So we selected a group of patients who would benefit the most. And as such, in my opinion, and Dr. Tonelli's opinion, that could actually exaggerate or amplify the benefit from inserting those esophageal balloon catheters. So that's one of the shortcomings of the study. The other shortcoming of the study is that we did not include patients who were not obese and they were lean, because we know that those patients do not have elevation in their intrathoracic pressure. And as such, we did not feel that inserting an esophageal balloon catheter in those subjects would change the hemodynamic classification. So we did not do that because we know that pleural pressure or intrathoracic pressure in normal individual is not high and is not expected to cause changes in the hemodynamic measures.
To make a counterpoint, I would support and say I'm not sure that's necessarily a limitation, right? In the sense that, yes, I understand it's an enriched population, but at the same time, this is the population where we would want to use the device and the measurements. And would that be a fair counter? Again, 100%. I'm asking from a clinical standpoint.
Yeah, 100%. We wanted to select the patient who would benefit the most from this intervention and who would have actually benefit from doing this. So I think that we should not be doing this in everyone, only in particular group of patients. So
Yeah. For example, if you have a patient that's morbidly obese, but the wedge is 5, I mean, to realize that the intrathoracic pressure may be 3, it doesn't really change the management. So yeah, always putting patients into context. In the future, we'll also be including COPD, maybe some thoracic chest wall deformities, and ILD. Other patients that may have higher intrathoracic pressure besides obesity, but that's kind of for the future.
And I was going to posit maybe even, this is always challenging with esophageal pressures, right, is your sort of local variations. And we always talk about it even when we're talking about beep titration. So I wonder how much that would impact it even within the same patient, but I suppose that's a question for another time. Is that fair?
Yes.
So, all right. So as a clinician, as somebody who does PH, how do I implement this in our lab or in the practice? Where do we get the most benefit? And what do I watch out for, or what to be careful about?
Well, ICUs nowadays are more and more comfortable with the placement of esophageal balloons for mechanical ventilation. So critical care physicians certainly have the skills, and the nurses also, to measure the esophageal pressure in the ICU setting. And also they put Swan-Ganz catheters for measurement of pressure in the ICU. It can certainly be done in a RAHA catheterization because most of these patients that we did, practically all of them, we did in the outpatient setting. But in the inpatient setting, it's certainly not complicated for an ICU that is used to put the esophageal balloons. The esophageal balloons, we use benzocaine to numb the throat, the gel in the nose, and then we advance the catheter to 35, 45 centimeters. We tend to measure the distance from the xiphoid process to the earlobe to the nose. And then we advance the catheter, and then we when we see the cardiac oscillations, we see negative deflection with inspiration and positive deflection with expiration. We know we are in the right place. We remove, there's a little wire inside, and then we get the measurements in different positions we do, but certainly you just need it in the supine, and it has to be at the same level you want to correct. So if you, like the guidelines recommend, measure everything at end of expiration, you want the end of expiration esophageal pressure, and then you subtract both, and then you get the adjusted measurement. You use a regular transducer, and you can use a regular monitor that you have on the wall. So it's really easily applicable to an ICU setting for sure. In a RAHA catheterization, you obviously need to train your nurses and just be sure that that you have all the connections appropriately in place, and you're recording the waveforms, because if you want to then do the analysis of the waveform, that will be the best way of being sure you're getting the end of expiration and the end of expiration in both the esophageal and vascular pressures. Right.
Avoid the tendency to pick from different parts of the cycle, or you'll over or undercorrect. Okay, beautiful. Yeah. Well, Dr. Khirfan, Tonelli, thank you so much for sharing the study. I have to say, and I always almost close by saying this, doing research is hard. So thank you. This is painstaking work. And I just wanted to appreciate you for the work you've done, and sounds like you have more ideas. So I look forward to seeing your work going forward in this area as well.
Thank you so much for having us. We're very delighted again. Thank you. Bye.
Of course. Congratulations. Take care.
Thank you.
Thank you.
Thank you.